Okay, so it's 7 o'clock, so I think we'll get going here just to be respectful of everyone's time. Hope all of you are doing really well. Hope we can have an in-person meeting really soon, so we can all get together again. Hoping the end is near for this pandemic. So welcome to all the peers from in Hamilton and outside of Hamilton for a great event tonight. We see it all the time as pharmacists, whether it's in hospital, community, or primary care settings. Patients with chronic pain on whopping great big doses of opioid, not even touching their intractable pain. Patients struggling with the most severe depression and not really progressing anywhere with therapy. So pharmacogenomics and pharmacogenetics may hold the key to better health outcomes for many of our patients. The Mayo Clinic, the Cleveland Clinic, Sick Kids, they all have pharmacogenomic programs. So we are the drug therapy experts as pharmacists. And after today's seminar with John, we really hope that you develop a sense of confidence to incorporate this in your practice site. And that's why we brought John here tonight to present to all of you peers. I wanted to take a moment to thank Sigrun Watson from Imaging Diagnostics for investing in pharmacy education here tonight. Great working with you to deliver this event. And I'll make sure I connect you all with Sigrun after the event. So without further ado, let me introduce John here tonight. So John Papastergiou graduated from the Leslie Dan Faculty of Pharmacy at the University of Toronto in 2002. After graduation, he was employed as a staff pharmacist at Sunnybrook Health Sciences Centre. And in 2005, John joined Shoppers Drug Mart and acquired his first store at Pape in Danforth. He now owns and operates 4 locations in downtown Toronto. And in 2014, John received an appointment as an adjunct professor at the School of Pharmacy, University of Waterloo. In 2016, he was cross-appointed at the Leslie Dan Faculty at the University of Toronto. In 2012, John was named Shoppers Drug Mart Associate of the Year. And in 2014, he received the OPA Mentorship Award and was named CPHA Canadian Pharmacist of the Year. In 2016, he was a recipient of the OPA Voice of the Profession Award and was awarded the Pharmacy Practice Commitment to Care Award for overall patient care. In 2019, John was named by the International Forum on Advancement in Healthcare as one of the top 100 healthcare leaders globally. He was also presented with the OPA Award for Excellence in Research and Academia. And it's a real pleasure to have him here today. It's a privilege, in fact. So thank you so much, John, for joining us.
Thanks, Eva, for that introduction, and thanks for having me here. This, I think, an exciting topic and a real opportunity for community pharmacists. And I've spent the last probably three and a half years of my academic life working in this space, and I've come really much to believe in the technology and what it could do for patients. So I was initially going to give a didactic type lecture, but we thought we'd change it and really make it more case-based. I'm probably going to pick on Steve a little bit, get his thoughts as we go through the presentation. I'll give a quick introduction, a little bit of background that I think is probably necessary, but if you're listening in and you want to unmute and throw in your 2 cents or your opinion, there's really no black and white answers in this space. So it'll be interesting to get the thoughts of the audience as well. But I'll start, at the beginning here, discussing how pharmacogenomic testing can be implemented in your practice. I think that's important. I think that's where many pharmacists struggle. We're all very, very busy. We see what's going on in our pharmacies right now, and you get presented with a new clinical program. You say, I'd love to do it, but how do I fit it in? So, I think that's an important part of this. From there, we'll move on to kind of some recent evidence. We just published a randomized control trial, one of the first ones globally in this space, and definitely the first RCT in the community, out of a community pharmacy. So we'll speak to what those results showed and how I think it's going to help propel this technology forward. And then we'll end with some real-world case examples and give you the opportunity to look at real patients we saw in a clinical trial and in clinical practice, and get some opinions. What would you do? Do you feel the testing helped? Would the testing change the way you thought of the clinical case? And that's really what's important. I am first and foremost a frontline community pharmacist. I own 4 Shoppers Drug Mart franchises in Greektown, and really early on in my career, I came from a hospital background. I thought, what can I do to kind of change my practice? We had many local independent competitors around me. Patients had a lot of options. So I became interested in things like point of care diagnostic testing. And we did a lot of the early work in that space, obviously immunization, and then more recently in pharmacogenomics. And our practice now is fundamentally built around some of these programs, and we've seen how the pandemic has kind of pushed us forward an extra 10 years or so, not only in the point of care space, but in, in diagnostic testing and obviously in immunization as well. What is pharmacogenomics? Really, genetics has been that one variable that historically pharmacists haven't been able to account for. We've all been able to, adjust drug therapy based on a patient's size, age, sex, renal function, hepatic function, but those drug gene variables or drug gene interactions were an area that we were never able to predict for, and that really explained some of those situations where we had two very, very similar patients, but when you give them a drug, they react very, very differently. And that's when we speak about pharmacogenomics, fundamentally, we're trying to predict how a patient metabolizes genes. And that's very, very important because only about half of the patients are what we call normal metabolizers and respond to a drug the way we would predict they would respond. The rest of them are either on one end of the spectrum or the other. So either they don't respond or they have a very, very suboptimal response, or they have side effects or toxicity. And we all see that in our practice every day. So if we're able to predict for patients that would fall in those two arms, we'd adjust therapy and hopefully get them a more normal response. I think this slide is important because the American Society of Health Systems Pharmacists put out a position statement. This is a few years old, but it really speaks to what I think pharmacists are capable of. And it said, because of pharmacists' distinct knowledge, skill set, abilities, we're uniquely positioned to lead the effort of pharmacogenomics and the expansion of this into clinical practice. So we're ideally suited to interpret test results and make the clinical decisions to do that. Why this is important? Because we're not the only ones interested in this space. As the cost to do these tests comes down, more and more patients will have access to it, and the real driver will be who's able to interpret the results. And if it's not us, I think it really will be someone else. So this is a call out that still applies to say, hey, pharmacists, this is a technology that's available. We have more and more evidence now to suggest it makes a big difference. Why aren't we using it in our practice, or how can we use it in our practice? So what's pharmacogenomics promising? Well, it really is around more informed prescribing. So getting patients on the right drug faster with fewer side effects. Other objectives are lowering drug costs there, lowering disability costs. So insurers are very interested in this space. And ultimately, patients should have better clinical or health outcomes. There's quite a bit of evidence now that when you do this and when you get patients on therapy faster, you save a lot of money. And obviously, that financial savings is going to be a driver as we kind of push forward and try to get third-party coverage for this technology, which is starting to happen already. And obviously, we like to see more and more of that, and ultimately provincial coverage, which is probably still a ways away. So do we have any evidence when we, what the promise here is that a response to drugs varies according to a lot of different things. And we talked already about that, but do we have any evidence that if you're able to predict those drug gene interactions, we can actually impact clinical outcomes? And I set on a few years back to try to help put some of that evidence together and really have some of that evidence come directly out of community pharmacy, with the hope that, hey, if we're able to show the value and show the value of the pharmacist behind this, hopefully other stakeholders will get behind this and help push this forward. Depression is a state, depression and anxiety is a space that we can measure pretty easily, or a therapeutic area that we can measure pretty easily. And we decided to do a lot of the work in this area because it was something that I thought pharmacists would be able to measure clinical outcomes over a period of time. And it's important, if you're going to show the value of this thing, that you follow patients for more than a little while. And we know with patients with depression, it impacts many plan members. Many of our patients, it's a leading cause of disability. Patients typically have low adherence. We know generally with any chronic disease, at about 6 months, half the patients will fall off. For depression, it's even worse than that. So if a patient's not adherent, they're not going to get the outcomes you're looking for. And then we've got this 1/3 of patients that do not respond to treatment. So our hypothesis early on was if we could show the value simply for depression, that's enough patients that maybe we could get an uptick in the number of pharmacists, third-party payers, stakeholders that are interested in this. Before our randomized trial, we actually published a paper called the ICANN-PIC study, and it was really one of the first papers in the pharmacogenomic space. And the idea here was to show that pharmacogenomics is something that pharmacists could do. They could do it within their workflow. They could do it within their practice. And more importantly, they could intervene based on the results. When we did this study, it was across a broad range of therapeutic areas. So not just depression. We looked at cardiovascular patients, GI patients, mental health patients. So it was a broad spectrum. What lacked in this paper is we didn't follow the patient. So we didn't look for clinical outcomes, like was there any improvement? We just wanted to show that pharmacists could do it, they could do it efficiently, and they could intervene. And the results, although a few years old now, were still quite interesting. We had some funding for this. We recruited 100 patients over 2 pharmacies. And we found a pharmacist identified about 1.3 drug therapy problems per patient. So there was issues in these patients. They were pretty complex. And we were going to use pharmacogenomics to try to resolve some of these problems. And what the pharmacist did with the results was interesting as well. 57% of the time, they used the genomic test results to change therapy. 14% of the time, they adjusted doses. 7% of the time, they stopped the drug completely. And 20% of the time, they had to increase some type of monitoring depending on therapeutic area. So we showed, hey, yeah, with pharmacists armed with this technology, they'll intervene and they'll use it to make clinical decisions. And that was an important first step. Because if we're simply testing and doing nothing with the results, there's obviously no point in it. So it really was to show, hey, we could do it. We could do it within our community pharmacy setting, and we'll actually intervene when we have access to the results. What we didn't have, and that's what really drove our subsequent project, was a key to, I think, a very important question. And that was, go back here, does clinician access to pharmacogenetic test results during routine clinical care improve patient outcomes? And what we found, in that first little paper there, that paper actually won first prize at FIP one year, which was a global conference. So it did gather a lot of interest. But the pushback we got was, well, we would have came to some of those conclusions even in the absence of a pharmacogenomic test. Maybe not on the first try. We would have tried a couple of things, but eventually we would have got the patient stabilized. And we really wanted to show that, when you have or when you're armed with a genetic test, you get patients on the right therapy quicker. And we know in mental health, that's very, very important because those patients will do better in the long term. So our goal here was to recruit 213 patients. We knew based on the first study that should give us enough power to detect the difference between our 2 groups. And one group was a controlled group. Obviously, that was a group we called the standard of care. The other group was our intervention group, which was the standard of care plus a genetic test. So really, the only 2 differences was one group was getting test results, and the pharmacist had access to those test results to intervene. But we did try to keep everyone blinded. We swabbed both groups, so they didn't really know, the patients didn't know which group they were in. It was only the clinical pharmacists that became unblinded when the results came back. Obviously, they had to interpret those results, and patients were randomized appropriately into those 2 groups. And what we found was we wanted to focus on mental health because we could measure those outcomes. We were powered at 200 patients. We blinded everyone, including the patients. And then what was the key difference from our first little study there is we followed these patients for 6 months. So that was very, very important because that would allow us to determine if there was any difference. We felt the timeline was appropriate, especially in mental health, to capture a difference if there was going to be one between those 2 groups. So we needed some outcome measures. So we dug into the clinical literature and pulled out some scales that we thought we could use in pharmacy. The primary outcome measure was the PHQ-9, which is really just a 9 question scale that the patient fills out that really assesses the severity of depression. But we had some secondary outcomes as well there. The GAD-7, a 7 questionnaire that measures a patient's anxiety, because we did have anxiety patients enrolled as well. And then there was the Satman-Q, which was really, it's a scale that really assesses the satisfaction of the patient with their therapy. So was it working? Are there side effects? And then finally, a more qualitative scale there around quality of life, the SDS scale, measures things like how the patient interacts in society, in school, and work, and all those other social functioning type things. So we really were taking a holistic approach to the way we were looking at these patients, I think, with the 4 scales. Just to give you like some context to what do these numbers mean. And if you look at our primary outcome measure, which is the PHQ-9, patient that scores anywhere between 5 and 9 on that scale would be a very mildly ill patient. So they might not even initiate therapy, but they would watch them closely. But you're anywhere between 15 and 19, you'd be more moderate, severe. You definitely would initiate therapy at that point. So it gives you some context to where these patients were as we go through this and where they ended up in the study. And then we measured them at baseline. So when we enrolled them, 1 month after, 3 months, and 6 months. And they did all 4 of those scales as they went through the study. And we had a lot of success retaining those patients. So really, what happened here? So when we randomized the patients, we had no differences between the groups. You see there, the randomization worked. About 76%, 73% female in both groups. Average age, very close. Baseline PHQ-9, you could see they were quite ill there. Remember, 13, 14 is the moderate to severe group. Same thing with the baseline GAD-7 and SDS. So they were pretty complicated patients, definitely requiring pharmacotherapy, but very important, no difference, statistical difference between the 2 groups when we started this. So they were equally ill, and no demographic differences between our control group. So what happened when we looked at these? It's not my favorite slide. This one's much better here. Look what happened. That's the control group, and that's our pharmacogenomic intervention group there at 6 months. You can see we achieved dramatic statistical significance over a 6-month period in our intervention group. You see the control group showed some improvement as well. We attributed that to the fact that standard of care doesn't really typically include these patients being followed so closely by pharmacists with scales. So there's some value in doing those assessment scales with patients, because the pharmacists were intervening in that control group as well, simply based on the scale. So you saw some improvement in that control group, but the pharmacogenomic arm statistically better, significantly better. And I think a good news story for us, really showing the value of pharmacogenomic testing with respect to depression. When we looked at anxiety and the GAD-7 here, we saw an equal improvement. So again, very, very positive story there, achieving statistical significance on our secondary outcome measure. And then when we look at our more qualitative social kind of functioning scale, again, achieving that same statistical significance. So all our outcome measures met significance, and I think really definitively showing that when armed with a genetic test, these patients will do better down the line.
John, I just wanted to say something. All those measures showed that the power of empathy, right, from the pharmacist, because the control group had significant results too, which is great to see. The power of
I think it was the pharmacists, the scales, and there is a movement to try to get pharmacists to use these assessment skills in practice, because simply talking and assessing these patients and seeing that they're having underlying issues kind of forces the pharmacist to intervene. And I think that was happening in the control group, because we did see a very high number of interventions in the control group as well. The only difference there being that they were using trial and error when picking subsequent agents, whereas in the intervention group, they were guided by the pharmacogenomic test results, and those results obviously getting patients on the right drug faster. And you see the lines start to separate. very, very quickly. About that 1 month period, you start to see a difference in most of them, really at 1 month there across the board, right? So it seems like
This is
when you do this, sorry?
this is amazing. Like this study that you did is amazing. Like it really showed the power of the pharmacist. Like
Oh
it's
yeah, we believe that. It's getting a lot of interest actually globally now because no one's really done something like this in pharmacy. It's very difficult to run a randomized trial in a pharmacy because of keeping the blinding is hard because there's so many patients there and so many different staff members and everything else. But I think we did a good job maintaining that. And then really what we saw is we saw these patients go from definitely a position of requiring pharmacotherapy at the start of the study to their base or their endpoint scores at 6 months being somewhere where they probably didn't need pharmacotherapy at that point. So really, again, I think a good news story overall. So we haven't really spoken about how this works. It's quite a simple process, and I think we'll get, we'll get to understand it a little bit more during the cases. But essentially, when you're offering pharmacogenomics, you have to partner with a vendor. So you have to partner with a vendor lab that's able to take your sample, analyze it, and then send back a report. And the value is really in that report where they take the genetic analysis and then interpret the results for you based on the most recent guidance. And there's a lot of guidelines out there that help interpret, the results for the pharmacists across about 200 drugs now. So when we started doing this, there was only about 120 drugs that were involved. That list continues to grow and grow as the background evidence around the importance of pharmacogenomics for more of these agents it continues to build. And that's really what we're using. So patient will come in, you identify them as a candidate, you suspect they have some type of drug gene interaction. Pharmacists get some training before you do this. You have to be aware of which drugs may potentially be implicated. The worst thing you want to do is offer this test to patients and there's no rationale behind it because it's still relatively expensive. So you want to identify the right patients. You take that swab, you put it into the vial, you throw it into the mail, and in a few days, usually about 4 or 5 days now, you get a nice comprehensive report back. Most of the companies now have very, very user-friendly portals. So you're logging in right at the pharmacy, you get notification that results are back, and you don't need to print these physical books, but everything is there. And actually, the portals become more than just a repertoire for the reports, but really they become tools that allow you to do pharmaceutical opinions and everything else right out of the portal, make those interventions, send them off to the physicians, collaborate with those physicians, and get the patient and intervene and get the patient on the right therapy quicker. So really the value, yeah.
Just sorry, mate, to ask a
No.
question. So that swab's really easy, to do. Like
Oh yeah, it's a cheek swab. So I mean, we've been doing COVID testing for so long now, but this was just a cheek. So generally, what you do from each side you do about 10, 15 swirls on one side, 10, 15 swirls on the other side of the cheek. You put it right in there, and you're done. That's enough. That's enough. Mix it up a little bit in the tube, and you're good to go. So you're just grabbing a nice sample of DNA from the patient that the lab is going to analyze.
And
So really simple. Yeah, I mean,
really
I would say the intranasal PCR tests that we're doing are harder than those. A lot of times you just hand it to the patient and they're doing it themselves. You're not really doing the swabbing, and then they just hand it back to you. But really, what the product is, what you're getting back though, is the pharmacogenomic test report, which helps translate results from the laboratory test. So it's taking the genetic test results into clinically actionable prescribing decisions for the drugs that we know are potentially implicated. And that's very, very important. So they're not just sending back some results. You're not looking at a lab result as it would come back from Life Labs or something like that. It's a result that also factors in guidance that will help the pharmacists make decisions. That'll become clear as we go through the cases. So it's not just the patient's genotype. It really is taking the genotype, the implicated drug into consideration, and looking at the guidance that's available and coming up with recommendations that are specific to that patient. And I think it's important to understand that. And that is really the value of those reports. So I think you see slides like this all the time. Simply having the technology available to us by no means means that we'll run with it and make it successful. I mean, we've had failures in the past, things like smoking cessation, where we actually have reimbursement for, and no one in the province is doing it. And there's reasons for it. There's a lot of documentation, limited reimbursement, and whatnot. But really, I think what we have to do as pharmacists is really understand the value of what we're talking about here, really understand how to do it, how to build it into our workflow, and then help our patients understand the value of it, because they've got a lot of misconceptions around pharmacogenomics. They don't really know what it means. A lot of times they think you're going to tell them what the risk for diabetes or heart disease is, and they don't always want to know that, or their insurer is going to find out what genotype they have around a specific cancer gene, and they don't understand that we're talking about hepatic elimination for the most part of drugs. And if we're able to predict for how those drugs are eliminated, we could get them on a more appropriate therapy. So really, that understanding is key to building the success of the program. And we see this across the board. I think we've seen it during COVID and COVID immunization. I have patients now coming for this service that have never been to my pharmacy. And if you're able to convert one of those patients to a regular patient in your pharmacy, they could easily buy $100 of meds a month over a 12-year period, buy a couple of OTC products here and there over 10 years. That patient's at $24,000. That's probably conservative now. And they bring in a friend, you're at 50 grand for simply doing a genetic test. So I think the value of this goes well beyond the service you're providing. It really is a clinical program that will change the way patients perceive you and the relationship with them. And I think that's very, very important as well. And I think I like to show this slide because it speaks to workflow in a typical pharmacy. At lunchtime, you see a pharmacist there trying to fill a script, techs on break. Someone asks him about a test or a flu shot or something like that. He ducks, and now he's getting inundated with questions, calls back tech, and that's me saying, why aren't you doing more? And I think the problem here is in that environment, you're not able to offer a service like this. It's more involved in a typical simple clinical program. You need to make appointments with patients. You need to review results with them. You need to collaborate with physicians and get them to intervene. And I think during times of drug reform and some of this other stuff, it takes a little bit of courage to invest in a program like this, where maybe our margins are becoming slimmer. We're seeing more generic depreciation. I think the value will be in being able to do stuff like this. And I think COVID has helped us because we've seen the gross margin dollars we're getting from some of these clinical programs. So really, ideally, you want to have a workflow where Green is a pharmaceutical tech, is a regulated tech there, maybe even having a clinical pharmacist being able to offer those suite of services, all within the context of the dispensing workflow as well. And I think that is easier said than done, and many of us are challenged with that right now as we're inundated with calls. And I know there's pilot programs running even within Shoppers Drug Mart and other chains right now with pharmacogenomics, and stores are still struggling with this. So it does take, there's no cookie cutter approach. It really does take figuring out what works best for you. But we do know for every 1.6 fold investment in labor, the return to bottom line profitability from clinical services is over 2 times. And if you ran these numbers again with some of the COVID services, can be much, much higher than that as well. So I think it is the future as we centralize. And these are things that we should be considering as pharmacists. Pharmacists are key to this. If they don't get buy-in, it's not going to work, because they're the ones that are identifying the candidate patients. They're identifying those drug gene interactions and patients that may potentially benefit. If you don't have buy-in, it's still too new of a clinical service that you're going to have patients walking in asking for it. I mean, that may come soon, but it's still a little bit of ways away. We do get a trickle of those patients, and we've been doing this for years and years, but it really still is sold by your pharmacist to the patients directly. Pharmacy techs are key. I think they're important to this. They have to understand the service, really understand what you're offering. They're the frontline face of your pharmacy. So if they get it, I think they'll be able to at least identify patients that may have that initial conversation with the pharmacist as well. Yeah.
Sean, I just wanted to say, mate, like, I think you reaffirmed another point. It's hard to lose money by investing in these services. I know pharmacist time is valuable, but if depending on how much you pay your pharmacists or technicians, like offering the service, it's hard to lose money, especially with this pharmacogenomics test, right? It's only really charged once the test is sent away, isn't it? So
yeah, oh yeah,
I guess there's no harm in trying.
No, there's no harm in trying, and I think right now many of us have more than one pharmacist in the dispensary because of all the other services that we're offering, right? So if you identify a candidate that may benefit, it's worth at least having that initial conversation, handing them, one of those buck slips or a brochure. And they don't always, they're not always convinced on that first conversation, but you start that conversation, they may look it up themselves. You'd be surprised how many patients come back. And that's what typically happens for us. I mean, we've run 2 trials now, been offering the program. We've done over 1,000 patients. So if you do the math on that, so obviously some of it was funded. Many of the patients got it for free, but I think as the price comes down, the value continues to be highlighted. We're going to start having patients coming to us. And I think as third-party payers cover it, that's going to be even another kind of story. So we're well on our way, but we need help from, I think, more and more pharmacists. So that's kind of some background. I went through it kind of quick because I wanted to focus on some of the patients here that we've got coming out of our study and studies or out of our clinical practice, and see, Siva, what you think and what maybe some of the audience thinks here today. So this is a mental health patient. That's a big group of our patients will be mental health. They were always the front runners of the patients we enrolled in our first study. But you see this patient here, 16-year-old female, ADHD, diagnosed at 15. She was given modified release methylphenidate for 4 months, but stopped due to lack of effect. And then she was given atomoxetine, 40 milligrams daily for 4 weeks, but again, stopped here due to headache and excessive sweating. So that was her most recent trial. She lives at home with her parents and brother. She's got some mild asthma, and you see her only other med is salbutamol there. No other significant findings, but the pharmacist now identifies, hey, we know this is a mental health condition that we may be able to get some value if we better understand the potential drug-gene interactions. So the pharmacist has now sent off a sample to the lab and is awaiting test results. Thoughts on that, Stephen? What do you think?
When I see a patient like this, thanks for asking, John. I see that she's 16 years old, right? So she's really young. And, she's at a stage in her life where her learning and development is really important. So this drug therapy failure can impact Jenna very significantly. And, the scenarios of both drugs, one being stopped for side effects and the other for lack of efficacy, it's something that we see in practice all the time. So if we're able to help her better, I think we can really help her in her health outcomes and even her life outcomes with ADHD, right?
Absolutely. And this is I find our like teen patients, younger adults really have the support of their parents as well. And they're really willing to pay for some of these non-covered services because their real concern and their ultimate goal is to get these patients better as quick as possible. So we do see a lot of these patients. So next slide here shows us kind of, and we've clipped some, obviously we can't show you how the entire screens look as you're going through the portal or through a printout. If you were to print it, we just use the portal. The portals are so slick and streamlined now. Imagene's portal, you can pretty much get anything you want on the screen very, very quickly. And we look here at our patient. The first drug they started was methylphenidate, lack of response. So what happens with methylphenidate? You see that down there. We've got first the ADHD drugs, and there's different ways we could look at it. Here we're looking by therapeutic class. What does that kind of orange thing with an exclamation mark mean? Any thoughts, Siva?
Does that mean it may or may not work? I'm not sure.
Yeah. So Generally, red is bad. We don't see any red there. Amber is like, could work. It doesn't mean we're not going to use it, but green is definitely better, a better option. So if we look at methylphenidate there, you see the implicated gene there is the COMP gene. That's more of a receptor gene. And it says here, you may have a reduced response to this medication. So it can mean different things. It can mean we may have to adjust the dose. There's a source there that's referenced. But as a first line option, if we saw this, we'd probably see what else is available before we made a decision. So either 14 years ago or at 14, when she started it, she wouldn't have had access to this report. The doctor was making a good clinical recommendation there, but there is a potential drug-gene interaction. If we look at atomoxetine or Strattera there, that was more recently described 6 weeks ago. We have here the patient is an intermediate metabolizer. So the metabolic genes or the CYP genes are responsible for about 90% of the clearance of these drugs. And you'll see them pop up, and they're the most common genes that you'll see on these reports. So the important gene here is CYP2D6. But what does it tell us here? You have an increased risk of side effects from this medication. A dose adjustment is recommended. Why is that the case with an intermediate metabolizer there, Siva?
Just in case, right? So
Yeah,
again,
so
just in case. You know, an earlier slide that you talked about, you said 2/3 might result in drug failure, right? So it's still a good guiding principle. So would you start this patient maybe at a lower dose and titrate more slowly? Is that something?
absolutely, that'd be an option right there for sure. So that if we had done that, we probably would have been able to, balance out those side effects. So the wild type, remember I showed that curve. The wild type is generally an extensive metabolizer, right? So that would be the 50% that would fall into that group. So when you get into an intermediate or a slow metabolizer, those are going to be the guys that are on the left end of that tail that have some type of a side effect, right? So or a total toxic reaction. So in this case, what we see in the genetic test results are what we saw clinically. So the patient actually discontinued the drugs due to side effects. And probably it would have been if we were armed with this at the beginning and we really wanted to give the methylphenidate, we would probably went at a 50% reduced dose and gone from there. And occasionally with the recommendations, if there is guidance on the amount of dose reduction, it'll be listed there as well. So sometimes it'll tell you 25, 50% or whatnot. So based on all of this, what would you think is the best bet for this patient?
Yeah. Either going at a lower dose with the atomoxetine or going with I would start with Vyvanse, even recommend Vyvanse instead, because at least dexamphetamine is green, right, for this patient.
That's what I would do. I think sometimes, you've already had the patient on it. Now you got to go back, reduce the dose. You're not really sure how much to reduce. I think I would go exactly with that. Of those green options, the best, clinical option for a patient with ADHD there would definitely be the Vyvanse. And I think that's what we would go for. And I thought I had another slide there, but yeah, that would be my recommendation. There's no black and white here, guys. There's no right and wrong answer. If you said reduce the dose of the atomoxetine, I think that would have been very, very fair as well. And I think that would have been an appropriate option. It may have been a slightly harder sell, depending on the nature and how bad the side effects were with respect to the patient. But again, you can see here, we're using not only the genetic test results, but our clinical judgment as well. And when you do the training, a lot of times you're trained by geneticists, and they I find lack that clinical side. We're very used to seeing patients with multiple conditions, different things going on. And I think it's that clinical intuition that you have that will help guide you as well, because you'll get test results sometimes that don't even make any sense based on what you're seeing, because there's other factors that are involved. There may be even genes involved that we haven't identified yet, right? So they're not going to always be black and white, picture perfect cases, and that's okay. And I think you got to be able to explain that to that patient that, hey, we're going to do this test, but 100% of the time is not going to be there's not going to be a clear answer, and we're going to hopefully use some of that information there to guide us in a way that we wouldn't have been able to do without it. So let's look at a.
John, I just want to ask one
Yeah.
question. So, you brought up an important point when you presented the case about cost, right? And I work in Beamsworth in West Niagara, a semi-rural area, and I think I'm really big on immunizations. And when I recommend Shingrix, for example, half of my patients pay cash for it, and they're more than happy spending over $300 to protect them from shingles. So I think you brought up an important point, man. I just want PS to recognize that, don't make the decision for the patient, offer it to them and let them decide, because often they will pay because of the value. And just sort of a summary to that last case, whatever you decide, you're much more further ahead in picking the right drug therapy, right? And you're much less likely to result in failure, right? So that's what I see from that case. So
Yeah, and we're it's substantiated by evidence now too, and that's, I think, important as well. And this patient would have been probably right out of the trial here. Ryan, 35-year-old man, general anxiety disorder with MDD there. So a dual diagnosis, age 28. He would definitely been a candidate for a study. He initially tried fluoxetine with very little success. He stopped that. He tried some cognitive behavioral therapy, but continued to have symptoms. Symptoms worsened 5 years ago. He was prescribed paroxetine, unable to tolerate that. He discontinued that 2 weeks later, and now he's tried sertraline, but hesitating to start treatment given his past experience. This is a typical patient for us, because like all of these patients had tried 2, 3, 4 agents a lot of times before they'd come to us and wanted to enroll. So you see there, he's been recently laid off. Remember some of those social functioning skills we talked about? He smokes cigarettes. He uses cannabis. A lot of these patients will try to self-medicate with cannabis as well. He lives alone there. And I think nothing else that's very, very important. But again, the pharmacist identified this patient as, hey, this is a candidate. If there's ever been one for a genetic test, let's test them. A few days back, we get some results, and let's have a look at what we see. So remember, fluoxetine was his first try there. He discontinued that due to lack of response, and now paroxetine discontinued due to side effects. Do our results here match what we see clinically? Siva, what do you see here?
It's just wow. When I look at this report, it's like, SSRIs aren't going to do a thing.
No.
And it's just, this is super valuable. And again, like you said, it's not an uncommon patient, especially one that you see during the pandemic with major depressive disorder going up. And yet, when we do meds checks, we see it all the time, right? An SSRI that hasn't been refilled, and it's incredibly hard to get that patient to go back for reassessment, right? Because they just think no antidepressant's going to work. Like, this report is amazing. Like, it's really.
So you see the reds right away, and like reds are generally, you're not going to waste your time on them at all. And you can see some of the very, very common agents there, right? Citalopram, Ciprolex, Paxil, all there. We wouldn't even consider those given this report. When we look at fluoxetine, which was his first trial there's a couple of genes that are involved. This is an important point here too, and I think Inagene does a great job highlighting this. Sometimes there's multiple genes that are involved, but they're not all weighted equally, right? So you'll see one gene say one thing, another gene say the other, but generally you want to look at the ones with the little pill beside them. They're weighted at a much higher weight. I find the metabolic enzymes in my clinical experience are the most important, more important even than the receptors. So, consider that as you're looking at that, because you're not going to weigh everything equally and kind of take a weighted average. You're really going to look at the most important genes. And as you go through your training, you get to know which ones those are. But in my clinical experience, they tend to be the metabolic enzymes. So fluoxetine here, based on our information, probably not a good choice. We may be able to adapt the dose, but a couple of issues there. Based on what you see here, what would you go with first line here?
I'd probably go with that levomilinocipran. I can't remember the proprietary name, but I'd probably go with one of those SNRIs.
I think that's a great idea. I think probably better than bupropion as a first line agent for depression. We do use bupropion, but not generally first line anymore. And let's see here. He's got the Paxil there. I mean, we already discussed Paxil. It's a poor metabolizer, no surprise. Poor metabolizers are going to get side effects at normal dose. So that's no surprise there. And then he's just been prescribed sertraline. If we look at sertraline, what does it say there, Siva?
Was just prescribed. You're
Remember
talking
that
about on the right-hand side?
Yeah, so look at the right. So the results are on the right-hand side there.
Oh, yeah. So he's got a specific gene mutation that may make this drug redundant in this patient, right?
Yeah, so he's an ultra-rapid metabolizer there, right? So
Oh, yeah.
what happens with ultra-rapid metabolizers at normal doses?
You just clear it right out, right? It's almost
Yeah,
like,
so they generally don't work. And this is a great case. I'll tell you why, because we see it. We have a patient that's had side effects on 2 of his initial medications, and then on his 3rd medication. What do you think happens intuitively by the prescriber when they've had side effects with the first 2? They generally start at a lower dose because they think, oh, this patient's sensitive. I'm going to start them at a lower dose. And we see this all the time. We start them at a lower dose because I think they're probably going to maybe sensitive, have some nausea. But if you start a patient that's an ultra rapid metabolizer at a lower dose, are they going to get any clinical effect? No way. You're supposed to be increasing the dose at that patient, or at least escalating it very, very quickly. So it's not a wrong answer here. We could probably try this, but if we actually used the genetic test results here, we probably at least start at a normal dose, if not at a higher dose, to try to get this patient controlled. So there's a lot of options there. It wouldn't have been wrong to give it any of the other agents. The SNRI, probably the best option, and that's why it has that little, see the little star in the middle of the green pill there? That means like that's your best option, right? So you could pick that, and I think you'd be doing fine as
John,
well.
I've got to tell you, like, I've got a lot of lister patients and a lot of adolescents with major depressive disorder, and so I really take note of what's going on, and I see this in practice, man.
You see it all the time.
Like I'll see people that'll need 200 milligrams of sertraline just to get an effect, and people on 25, why are they even doing it? So
as you do more and more of this, you see that there's patterns too, eh? Because you get to know the enzymes and the mental health drugs. It really is just a handful of enzymes there, so you get to know, and right away you see it, and you pretty much know what to do. Smoking is key here. Why is smoking key? What happens with metabolic enzymes if you abruptly start or stop smoking? Anyone know?
Because smoking is an enzyme inducer, right?
That's right. Eh? So that's another factor here. I mean, we didn't really talk about it because I don't think he's changed his smoking habits, but that's another thing you kind of, can mess everything up because you're inducing different enzymes. If he's a caffeine drinker or, a coffee drinker, that can muck things up as well. So there's considerations you have to look at also. And then he's a cannabis smoker. And Inogene's report is also very unique in that patients, and we published a paper of the pharmacogenomics of cannabis, and the results were really interesting. A third of the patients had really interesting genetic variants that would have implicated their cannabis use. I'm not going to go through all the genes and what's involved. We can do that at another date, but the report will tell you, and it's clear in this patient, you should be recommending the patient use a strain with high CBD, because if you go with a more potent THC derivative, the patient's going to have potential psychogenic side effects. So I think it's important to recognize that as we start counseling more and more patients around cannabis use, this is a very powerful tool as well when you're helping them pick a strain. And we do have a recent paper that looks at that as well. So you see here, this is going through the different options for the patient. And I think what we talked about makes a lot of sense. And I think really you could pick a number of different agents. So as we shoot through this, because we're getting near on time here, we've got a 62-year-old female here, pain and associated low mood, secondary to her mild rheumatoid arthritis in the hands. So she's gone to her rheumatologist. He suggests a trial of Humira, but she's wary of cancer risk. She's read online some things about cancer. She was given infliximab IV prior to this, and she stopped due to infusion-related reactions and lack of benefit. You see the methotrexate was tried there, and a number of different agents for pain, Tylenol 3, OTC, acetaminophen, ibuprofen. So a lot of issues in this patient. She's retired, lives at home. She's a smoker, pre-diabetic. She's currently on Paxil for her depression with trivial benefit. She had also tried citalopram. So we're talking about a patient here. If you know the drug classes that could be potentially implicated, there's a lot of value in doing a pharmacogenomic test here, because she's got potential trials coming with opioids. We know there's a ton of evidence there. She's got her mood disorder. Biologics, which are very, very expensive drugs, have important drug-gene interactions, and you'd ideally want to have some more information before you put them. You see she's tried infliximab and failed there, and now you see some findings there around her hands swelling up. But I think this is a very complex case. Probably not a case I'd suggest trying right off the bat, but a lot of potential information that could be gained from the test results. So we send them off here. And I think when you talk about, before we get to that, Siva, when you talk about pain and rheumatoid arthritis and mood, what do you think the first thing you want to tackle is?
I think obviously the pain will affect the mood, right? But like this woman just looks like she's having a horrible life right now. Leaving that rheumatological disease untreated, it's just horrible, right? The quality of life is just extremely poor.
So that's our priority. You fix that. I think you're going to fix the pain and probably help with the mood as well, right? So I think that's the way. If I were ranking the priorities here, I'd say let's figure out what our best treatment for the RA is, and then we'll worry about everything else. Because you can probably, if her RA gets better, you may be wasting your time tinkering with everything else here. The slides unfortunately went in kind of a weird order here, but we're looking at some of the analgesics. She said she's tried them all. You see ibuprofen, acetaminophen, not great options for this patient. Codeine, also not a great option. I find codeine's never really a great option. Codeine's a prodrug, right? So it gets activated into morphine. So the way you think about the metabolic enzymes changes now. They're reversed, right? Because it's activating the codeine. So poor metabolizers will give you a less effect as opposed to a more potentially toxic one. Methotrexate here, she's tried that again. Few genes implicated there. Again, not a great option for this patient, but we want to focus on the immunosuppressants first. Remember, she tried infliximab, TNFA variant. You'd be less likely to respond to this, and that's what we saw clinically as well. But what do we see about the Humira here? And that's a big green check mark. No potential drug-gene interactions there. So if we were starting and we had this, we probably should have went with this drug first. Hopefully get her stabilized on this, and hopefully all our other problems disappear. We could take a quick look at what she tried before. So you see citalopram there. She's a rapid metabolizer. So what would that tell us? We should probably have increased the dose on the citalopram to get her more controlled. And then with Paxil, she's got a gene variant there that would give her a reduced response. So clinically, probably not the best options, but you see a couple of good green ones there that we could have tried in this patient, or adjusted the dose of a couple of the other ones. So there's a lot of options here, but ideally in this patient, I want to focus on getting that RA under control, and then hopefully some of this other stuff would have resolved on its own. So I shot through a lot there in a short period of time. Thanks, Siva, for being my assistant through those cases. Generally, that's a more advanced program, but I think you guys did a great job. And there's some ways that you can reach me if you have any questions. I'd be happy to answer them.